I'm Lauren Henke alongside my co-host Stephen Chun for a Veterans Day episode of the NRG Oncology podcast. On this Veterans Day, we'd like to first and foremost thank all of our military personnel and families for their service and sacrifices for the nation. Today, we're joined by Dr. Vlad Sandulache, Chair of the NRG Oncology Veterans Affairs and Military Treatment Subcommittee. Dr. Sandulache is the otolaryngology service chief at the Michael DeBakey Veterans Affairs Hospital in Houston and vice chair of otolaryngology research at the Baylor College of Medicine. In these roles, Dr. Sandulache has played a pivotal role in expanding the NCI-sponsored clinical trial program for our veterans, both locally in Houston and also at the national level.
People may not realize that the Veterans Health Administration, or what we often call the VA, is the largest integrated healthcare system caring for cancer patients in the United States, treating hundreds of thousands of cancer patients annually. The VA has also had a long history of cancer clinical trials, such as the VA-Larynx trial that demonstrated locally advanced laryngeal cancers or cancers of the voice box could be cured without removal of the entire larynx. Dr. Sandulache, before we get too much into the NRG oncology program at the VA, could you just start off by telling us about the scope of the cancer problem in our veterans and why our veterans are disproportionately affected by cancer compared to the general population?
Thank you for the opportunity to speak with you today. It's a privilege to be part of NRG Oncology and to have the opportunity to work with dedicated colleagues to increase participation of veterans in clinical trials. I think that if we look at the veteran population, we need to keep a couple of things in mind. The first one is that they differ from the general population as it relates to exposures. Some of these exposures are what we would call unavoidable exposures, and these apply to individuals that are deployed on the ground, at air bases around the world, or on ships around the world. And they include things that naturally come to mind: diesel fuel, jet fuel, chemical cleaning products, firefighting foams that are utilized with high frequency in fairly close quarter spaces and generate disproportionate exposures compared to what you might see in individuals in the general population. So we would call those unavoidable because it's really part of the job of being deployed overseas and working on ships, working around heavy equipment, working around airplanes. And then there are accidental exposures that the general population experiences, but the veteran population experiences because a lot of times they're deployed in countries that don't necessarily have robust infrastructure. So, for example, contaminated water would be something that a veteran might be exposed to at a higher frequency than somebody in the general U.S. patient population. So exposure is probably number one. And the second one, or a close second, would be habits. The Department of Defense has either given out cigarettes as part of rations or provided the means to acquire cigarettes for our nation's veterans going back to the First World War and the Second World War and every international conflict after that. So you're sort of in this situation to where, on the one hand, the DoD provides support for the habit of smoking, and then the VA has to deal with resolving the habit of smoking. What we see in our veteran population is very significant rates of exposure to cigarette smoke, both firsthand and secondhand, really over decades, both during their time in active service and also during the subsequent period of time. Between these two things, you're looking at a disproportionate impact of solid tumors and hematopoietic malignancies that are associated with toxic exposure and bad habits.
With that in mind, not only these added exposure risks and perhaps the incidence that follows, but the VA itself is enormous. Can you give us an overview on cancer care delivery at the VA? I would imagine that the sheer size of the VA healthcare system poses enormous challenges for the integration of cancer care in clinical trials. When you think about it, it's really like the most enormous cancer center in the nation. How does the VA integrate its cancer program and clinical trials across its vast network? Are there unique regulatory challenges that you face at the VA compared to other systems?
That's a great question. I like to say that the VA is the largest horizontally and vertically integrated healthcare delivery system in the United States and, potentially the world with some exceptions in some of the larger European countries. So there are challenges, but I think one of the things that you realize once you start to practice oncology within the VA is that there's tremendous advantages to being in the VA system. The first one is that for my entire adult life, the VA has had a fully integrated EMR. And by fully integrated, I mean I am able to follow a cancer patient from Houston through Denver, through Florida and Alaska, look at their CT scans, look at their tests, look at the notes at all of these different institutions, not just look at the reports of the CT scans, but actually be able to see the images myself. And then in addition to that, because everything exists within sort of the VA firewall infrastructure, I have the ability to communicate with providers all throughout the country about an individual patient without any concerns related to privacy or some of the other aspects that impair communication amongst physicians sort of in the private world that have to cross institutional boundaries. So I think the integrated EMR, although it's antiquated, is an exceptionally useful tool in our oncology practice. The structure of the VA also helps. So the VA is organized into VISNs, which are essentially integrated networks that work across cities and occasionally will cross boundaries of states depending on the population density. And what that allows us to do is to easily transfer patient care from one institution to another institution within this integrated network and provide comprehensive care as the patient needs it. We also have the ability to perform intra-VISN consults, what we call interfacility consults. And to give you an example, I can see a patient at the Houston VA who was referred to me by a provider at the, let's say, Phoenix VA, whose transportation was arranged through the VA system, whose hotel stay or stay at the Fisher House is arranged through the VA system. That individual can travel as part of their VA benefits from Phoenix to Houston, get their care in Houston, get their diagnostic imaging in Houston, and then have the ability to travel back to their home institution. And that's all within the existing VA infrastructure. So that's tremendously helpful for patients with complex cancers, patients who need transplants, or patients who have significant chronic diseases that require advanced level of care. Within the VA network, we have individual institutions that are COC accredited either as part of their academic affiliate or, much like our VA, are standalone COC accredited cancer centers. So that provides a higher level of comfort in terms of the delivery of multimodal cancer treatment, because that accreditation does require you to meet some critical standards of cancer care delivery. And the one thing that the federal government is incredibly good at is keeping track of things and ensuring that all of its institutions are accredited to whatever standard may be most relevant at any given time, which in the context of cancer care obviously works to our patients' advantage. One of the areas in which is this particularly relevant is in the field of radiation oncology. A lot of effort has been put in over the last decade to increase the footprint of radiation oncology within the VA, to increase the number of sites that can deliver radiation on site, and in the process of doing so, to ensure that all of these sites are accredited using national standards, national metrics. And part of that is one of the things that allows us to participate in NRG oncology clinical trials.
With this in mind, Dr. Sandulache, I wonder if you could talk about the NRG oncology program and the broader NCI-sponsored trial program within the VA system. Does the VA have specific goals or benchmarks related to NCI-sponsored clinical trials? And given that both the VA and NCI are federal agencies, how closely are they aligned in terms of goals and priorities?
I don't know that the VA as a whole necessarily has a specific benchmark for clinical trial participation. I can infer that the goal is to provide the opportunity to enroll in oncology clinical trials to as many veterans as possible based on a few things. So the VA has its own internal clinical trial program. It's the clinical studies program, which is essentially designed to act almost as a counterpart to the NCTN network and some of the adult cooperative groups within the VA. The CSP has really pioneered some of the large multi-VA, multi-institutional studies looking at early-stage lung cancer or prostate cancer. And that program appears to be increasingly aligned with the NCTN network through Navigate. Navigate is literally a joint venture between the NCI and the VA to increase accrual of veterans to NCI-supported and NCI-funded clinical trials. So one of the things that I sort of see happening in the future is that this natural alignment, I think, is going to increase. And I wouldn't be surprised if the CSP program within the VA becomes really fully integrated within the NCTN network. And we really sort of go down the route to where we design clinical trials that are appropriate for a veteran population, or identify clinical trials that could disproportionately accrue veterans because of a specific risk profile or a specific disease. But it's all really done under one joint umbrella where the VA and the NCI collaborate closely. One other thing that I would point out is we're all used to the central IRB. I think it's important to point out that the VA has its own central IRB, which has been a huge boon for investigators within the VA that try to conduct multi-institutional trials. And again, I see increasing potential alignment between the central IRB and the VA central IRB, which I think would significantly decrease the regulatory hurdles that sometimes are the biggest obstacle to trial initiation and activation.
So, the Energy Oncology Veteran Affairs and Military Treatment Subcommittee is one of the newer initiatives rolled out by Energy Oncology in 2022, and you've served as chair of the group since its inception. What sort of issues has your group worked on, and what kind of success have you seen so far?
Well, I think the metrics for success for any committee or subcommittee really start with accrual of patients and making a connection between investigators, appropriate clinical trials, and the patient populations. With respect to that endpoint, I think we've seen success in the sheer number of veterans that we've accrued during this period of time to Energy Oncology and other cooperative group trials, and that number's gone up. Can we do better? Of course. Are we trying to do better? Yes. Some of the challenges have to do with some of the alignment, the design of the trial, some of the regulatory difficulties that I just covered, and our ability to overcome those. But honestly, I think a lot of the impact of a committee or a subcommittee is also the ability to just bring people together and identify people that can overcome different obstacles. So Maria Kelly, in her position as the radiation oncology director, as it were, for the VA, she has had tremendous ability to bring together radiation oncologists and medical oncologists from across the VA infrastructure and really identify the points that would preclude clinical trial activation at some VA sites. A lot of our VA accrual is honestly thanks to two individuals, Ryan Burry in Florida, who's going to be the new vice chair of this committee, and Elizabeth Corrin in Milwaukee. These are individuals that have been able to consistently accrue to multiple clinical trials across multiple disease sites. And one of the things that the subcommittee does is it gives the rest of us an opportunity to learn from their successes and to learn from each other's failures. On a more strategic level, one of the things that we've tried to do is work within both NRG Oncology and across the adult cooperative groups, learn from some of the other cooperative groups, in particular SWOG. SWOG has been very effective at deploying a hub and spoke model within the VA. Part of that has been related to funding, but part of it has been related based on their pre-existing relationship with Navigate. So what the subcommittee does is it tries to bring together all these disparate pieces and try to reduce the barriers, both regulatory, financial, personnel, to activating the relevant clinical trials across different VA sites so that our veterans can participate in these trials.
Recently, I had the pleasure of caring for a veteran who was insured through the VA, who I consented and registered for a clinical trial. I was very pleased that all of the services I requested through VA insurance, even proton therapy, were approved. But when it came to the clinical trial, I was surprised to find out that the VA insurance plan didn't provide what were called clinical trial benefits, so he had to come off of the trial. I don't know if it was something specific to this trial, and I don't pretend to be an expert on VA insurance policy, but could you speak to the kinds of options and the rights that VA-insured patients have to access clinical trials, whether it's in the VA system itself or outside of the VA system at an institution like mine?
Good question, hard question. I think the only thing harder for a physician to figure out other than private insurance policies and procedures is to try to span both the private sector and sort of federal policies. And I think what you're dealing with in this case is a very complicated sort of financial scheme to where the actual money comes from the VA budget. The insurance per se, or at least the insurance product, is not really VA insurance. It's usually an outside party, for example, TRICARE, which acts as, and I'm not an insurance expert, but to the best of my understanding, essentially an insurance provider. And then at the receiving end, you have the outside institution. So you really have three people that are participating in this financial and regulatory and administrative transaction, as opposed to just the usual two: insurance company, hospital / provider. So it's a little hard to figure out at what point things get lost in translation. What I can speak to is my experience. Standard of care is standard of care. Oncologic standard of care is very clear. It's defined by NCTN guidelines and national guidelines and FDA-approved therapies. The VA policy is and has always been that if you cannot get standard of care treatment, whether it's for an oncologic reason or other pathophysiologies within the VA will cover that care in the community. Now, some of these things are a little bit tricky. For example, protons for head and neck cancer are an option. I don't know that we would necessarily call them the definitive standard of care. So just like some insurance companies will cover and some insurance companies will not, you can see, depending on sort of what year we're talking about, whether or not the VA would approve protons versus photons. In terms of clinical trial participation, I have had patients leave the VA to participate in clinical trials successfully at outside institutions. I think a lot of that has to do with what type of clinical trial it is. So, for example, standard care versus standard care clinical trial, I think would be very easily covered, at least in my sort of rudimentary understanding of the finances. And I think the other part has to do with really the clinical trial coverage and the ability to navigate what's really clinical trial costs and what's not. And I think having done clinical trials myself, the coverage tends to get kind of sticky even when it comes to insurance companies. My instinct is that in this particular case, there was probably insufficient communication and insufficient sort of higher level decision making at the level of the VA and potentially the insurance provider. But I don't think that this has to be an obstacle that can't be overcome. Unfortunate for this patient, but I don't think that we should necessarily take it as a sign that clinical trial participation for veterans is blocked or prevented.
On this Veterans Day, I want to come back full circle to our veterans as we're starting to wrap up. For the veterans out there who are being treated for cancer, could you speak to them directly? What kind of hope and advice would you give them in navigating their diagnosis through the VA system?
What I tell my patients at the VA is the same thing that I tell my patients across the street at the academic affiliate. First of all, be vocal and persistent. There's no substitute for that. Whether it's head and neck cancer, prostate cancer, coronary artery disease, Crohn's disease, you are always going to be your best advocate. And I encourage all of my patients to be vocal and persistent. Some of them take that to heart. For some, it comes with a lot more difficulty. We have a lot of single elderly men and women who really don't have a huge support network, who don't necessarily have significant means, who have to travel long distances. To really stand up and advocate for yourself and to say, I do have a problem, this is my problem, talk to me, give me solutions, give me treatment, is challenging. But I think as much as possible, my advice would be to be vocal and persistent. The second thing, and I tell veterans the same thing I tell my patients across the street, is ask questions. I tell everybody, it doesn't matter what I think I said. It doesn't matter what my colleagues think we said. It doesn't matter what plan we think we came up with. The only thing that matters is what you understood and whether or not what we said made sense to you. And if it doesn't, then you keep asking questions. One of the good things that, again, we have within the VA is for a lot of the larger sites, we do have integrated multidisciplinary teams. We do have strong social work and case management support. And veterans do have some unique avenues for interacting with their providers. The VA was one of the first to pioneer virtual visits and telehealth, which allow us to constantly reach out to veterans and not have to make them travel simply to ask questions or to have another visit. So I think those opportunities really come in handy when you're encouraging people to ask questions. And then the last one is just don't suffer in silence. The VA is here to help you. The doctors at the VA are here to help you. If you have a problem, bring that to the attention of your physicians and make sure that the care that you receive is the care that you expect. It's a large system. It can be cumbersome. On the other hand, there is a lot that translates from one VA to another, which does simplify the problem for some of our patients who move from one city to another or one state to another. So that continuity can help. But cancer is always challenging. It's challenging for veterans and non-veterans alike. And the degree to which they and their families advocate and sort of stay persistent, I think, makes the biggest difference.
Well, Dr. Sandulache, thank you again so much for joining us today on the NRG Oncology podcast and elucidating so much about the VA system. And thank you once again for taking care of our veterans.
Thank you.
On this Veterans Day, we were joined by Dr. Vlad Sandulache, the chair of the NRG Oncology Veterans Affairs and Military Treatment Subcommittee, on his work to expand clinical trials for our veterans. We salute all of our veterans and service members out there, and thank you for your service to our country. If you haven't subscribed yet, Lauren and I invite you to follow us on Apple, Spotify, YouTube, or wherever you get your podcasts. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. I'm Stephen Chun, co-host of the NRG Oncology podcast. Thanks for tuning in, and happy clinical trials.